All right, so first let's talk about potassium distribution. And we've talked a little bit about this already, that potassium requires a little extra thought because of this relationship, that almost all of the potassium in the body is inside of cell membranes where we can't sample it, right? So if we look here, 4,000 milliequivalents versus 60 milliequivalents in the extracellular fluid, right? So it means that at any given time, most of our potassium is inside of cells. Now, the intake and output of potassium are still through the extracellular fluid, right? Because if the intake is going to come through the GI tract, the output is going to be urine and feces, but the source of both of those is going to be the blood, right? So the most potassium is inside of cells, but we have to work with the extracellular fluid to manage it. All right, so what matters more in potassium homeostasis than total amounts of potassium is where the potassium is. Because of this relationship, if I took only 1% of the potassium that was inside of cells and shifted it into the extracellular fluid, we would have a very high increase in potassium because there's so much of it here. So rather than looking at intake and output as the cause of our derangements, the issue is more things that shift potassium into cells or out of cells, right? Things that shift potassium out of cells are going to tend to increase your potassium level. Things that shift potassium into cells are going to decrease your extracellular potassium level. Okay, so some things. Insulin. Insulin tends to shift potassium into cells. It's because insulin, when insulin opens the door that lets glucose through, right? Well, that door is attached to a potassium transporter. So for every molecule of glucose that enters the cell, you get a molecule of potassium that enters the cell too. So it means that if we give insulin, we see the glucose fall and we see the potassium increase. Right? Or sorry, potassium decrease because the potassium's entering as well. To such an extent that when we treat patients for type 1 diabetes, something called diabetic ketoacidosis, when their blood sugars are very, very high, as we treat them and their blood sugars fall, their potassium levels fall too. And sometimes we have to actually add some back because they're moving so much potassium into cells that they end up with trouble. Okay, so that's one thing. Aldosterone. Now, we've talked about how aldosterone affects the kidney, but remember, aldosterone is released in response to increased potassium secretion by a separate mechanism than the renin-angiotensin-aldosterone system. So aldosterone, one of the ways that it decreases potassium, one way is it increases potassium secretion, but the other way is it shifts potassium into cells out of the extracellular fluid, and therefore it lowers extracellular potassium. Beta adrenergic stimulation does this. That's sympathetic nervous system, right? Specifically the beta cells, beta receptors, and alkalosis. Remember, we have an acid-base talk coming, but alkalosis all by itself tends to decrease extracellular potassium. I'll show you the mechanism of that in our acid-base talk. Now, other side of things, things that tend to shift potassium out of cells, in other words, increase your potassium concentration. Insulin deficiency, okay, that makes sense. It's on the opposite, right? So patients who have insulin-dependent diabetes, they tend to have an elevated potassium level because of poor glucose translocation, right? Aldosterone deficiency tends to increase potassium. Adrenergic blockade, okay, acidosis, and then cell lysis. This one's a little different than the others. There's no matching one. If you break open a bunch of cells, you're going to increase the potassium concentration of the extracellular fluid, right? Because of this relationship. Strenuous exercise. This isn't exactly cell lysis, but when we challenge cells, they do tend to leak out potassium. So if you have a lot of tissues that are busy for a long time, we will see an increase in extracellular potassium. And then anything that causes an increase in extracellular fluid osmolarity. Okay, that tends to increase extracellular potassium too. All right, so a lot of things can affect this system. I think I've told you before, you're going to chase potassium levels more than once in your life with a patient because of this relationship, frankly, that we have a lot of potassium in our bodies, but it's all locked away where we can't do anything about it. Yeah.
Can you go over the aldosterone again for the factors that shift into the cell?
Here?
Yeah.
Like why does it happen?
Yeah.
It is related to, it isn't a sodium potassium pump issue.
Yeah.
Okay? Aldosterone tends to increase the permeability of cells to potassium. Yeah. Good question. All right, so at the kidney, okay, if potassium levels can change all these ways, and we need to have potassium concentration stay in a relatively narrow range, it means that we have to have some regulation of this system. Okay, so how is potassium dealt with by the nephron in general? Well, it's freely filtered. It's a tiny, right? So of course it's freely filtered. It's going to come out of the glomerulus into the filtrate. 65% though of the entering solute is going to be reabsorbed practically immediately, right, in the proximal convoluted tubule. We see very little potassium movement in the nephron loop, okay? But as we come back up here to the proximal convoluted tubule, or distal convoluted tubule, then we see a further reabsorption, another 27%. And then we get some secretion and reabsorption along the way. But most of it is happening in the proximal convoluted tubule and the early part of the distal convoluted tubule, right? So filtered extensively, PCT, DCT. The PCT is obligate reabsorption. The DCT is modifiable reabsorption, right? So this line, this number and this number can be modified, right, as the body has needs. All right, so principal cells are our primary potassium secretors. All right, so these are the principal cells, and we have a couple of key players. BK is the big potassium channel. All right, so this is the tubular lumen. All right, this is the basolateral membrane, peritubular capillaries. Right, so BK is big potassium. The ENaC is the epithelial sodium channel, and the ROMK is the renal outer medullary potassium channel. Okay, so we have our ATP pump, right? So sodium is being pumped out, potassium is being pumped in. Remember, this is the peritubular capillary side. This is flowing along. Much of the potassium has been already reabsorbed, right? So by the time we get over here, we have a fairly good concentration gradient from inside the cell to tubular lumen, right? So this potassium is being excreted into the urine down its concentration gradient, right? Powered by the sodium potassium pump, okay? So sodium is being reabsorbed, potassium is being secreted. Now, intercalated cells also participate in this. Do I have a picture of that? No, I do not. Intercalated cells, remember, are acid-base cells, intercalated A, intercalated B, and they participate in potassium regulation by exchanging hydrogen ions for potassium, right? So type A cells reabsorb a potassium and secrete a hydrogen ion. So we're going to do that if we're acidotic, right? Because we're getting rid of hydrogen. Type B cells do the opposite. They secrete a potassium and reabsorb two hydrogen ions. This intercalated effect is why the alkalosis and acidosis lines in this table, okay? So when we're alkalotic, type B are prevalent, so we're going to tend to decrease potassium because we're going to be secreting it. If we're acidotic, then we're going to tend to reabsorb potassium while we secrete acid, right? So if we're acidotic, we're going to tend to have an elevated potassium. If we're alkalotic, we're going to tend to have a reduced potassium concentration, all because of this, because of the exchange of sodium for potassium. It's a kidney trick. You know, they're both cations, one positive cations, and the body is essentially has a transporter to, we would rather have an upset potassium and a normal acid-base balance than the other way around, right? So essentially we're trading one problem for another, but we handle the potassium issues better than we handle the pH issues. All right, so in addition to the reabsorption and secretion, there is also I've been hinting at this, aldosterone is released in response to excess potassium, separate from any cardiovascular cause, right? So this isn't the sodium retention side of things, okay? Instead, what we can see here is so this is extracellular potassium concentration on X, and on the Y, we have urinary potassium secretion, all right? So we have essentially two effects that both have the same pattern, right? Both of these curves, as potassium concentration increases, excretion increases. Do you see that? So both slopes are this way, all right? The red line is the effect of aldosterone, okay? So when aldosterone is present, as extracellular potassium goes up, the amount of aldosterone released also goes up, okay? But even if we didn't have aldosterone, even if we took that system out, that's the black line. Increasing extracellular potassium concentration will also directly increase urinary potassium excretion as well. So we have sort of an automatic system, that's this one, but we don't usually see the effects of that because aldosterone is the better controller, right? So even without aldosterone, we'll still increase our potassium excretion if our potassium is high, but typically aldosterone is our primary mechanism, right? So increased extracellular fluid potassium, that increases sodium potassium pumps, that favors, so it increases the uptake and intracellular fluid potassium concentration. So it favors reabsorption, all right? Why? Well, it's about concentration gradients, right? As the plasma concentration gets higher, the concentration gradient between extracellular and intracellular fluid gets smaller. Remember that, right? ICF has a lot of potassium. ECF has a little. If we increase the amount of potassium in the ECF, we've shrunk the concentration gradient. So it's easier for the sodium potassium pump to do its job, right? We've reduced the potassium gradient because we have high to higher instead of high to lower, right? So our gradient gets bigger. Now, increased potassium intake also, so like as our potassium creeps up, we upregulate potassium channels too, right? So the more potassium we have, the more potassium channels we make, extracellular potassium. Aldosterone levels respond to potassium concentration. I just told you this is the proof of it, right? So as potassium concentration goes up, aldosterone concentration goes up. How does that help us? More potassium, more aldosterone, more sodium potassium pumps, more potassium excretion, right? So that's the mechanism here. It's a classic negative feedback loop. So your potassium goes up, your aldosterone secretion goes up, more pumps are made, that drives your potassium level down. Then the system turns off. So it's a classic little feedback loop for aldosterone. Now, do remember, one of the things that I think is sort of quirky about this system is, yes, this system works fine, but aldosterone makes sodium potassium pumps. Sodium potassium pumps only do one thing. So whether the aldosterone is because of the need for potassium excretion or the need for sodium reabsorption doesn't really matter. The effect is the same because it's the same mechanism. It just has two stimuli. One is potassium, one is fluid balance, right? And renin, angiotensin, aldosterone. Okay. So essentially, aldosterone keeps our potassium concentration constant. Okay, so x-axis, increasing potassium intake. We just looked at one of these for sodium, right? So increasing potassium intake here, plasma potassium concentration. When aldosterone is present, big changes in potassium intake make only a tiny change in potassium concentration. This is what we want. We don't want to have to measure the potassium we're taking in, right? We want our bodies to just handle whatever we put in there, right? Now, if we take the aldosterone system away, we see the opposite. We see the backup system, right? We see this system, right? So it's a little slower, but it still has the same direction. But we see now that as our potassium intake increases, our potassium concentration also increases. In other words, the backup system can't keep up, right, like aldosterone can. So potassium increase, or potassium intake increases, that increases our concentration of potassium, that triggers the increase in aldosterone, and it triggers potassium secretion in the cortical collecting tubules directly, right? So this line is the aldosterone curve, this is the backup curve. Both of those increase potassium excretion, which fixes the problem, right? Matching our intake to our excretion. Now, one of the sort of quirks about potassium and sodium and how they interrelate is this idea of tubular flow rate. So if we increase our sodium intake, all right, well, what will come next? We're going to increase our fluid intake, right? Because we're going to manage our osmolarity. All right. So those things are going to tend to increase GFR because of the increase in plasma volume, right? So we're going to increase our plasma volume because of increased fluid. And as our sodium intake increases, our aldosterone release is going to decrease, right? Because remember, aldosterone is a sodium retainer. So if we have too much sodium, if we increase our sodium intake, our aldosterone is going to go down. Okay, now, as our sodium intake goes up, the proximal tubular sodium reabsorption, okay, so look at that for a minute. So proximal tubule sodium reabsorption, that's going to decrease, right? Because we want to get rid of more of it. See? So we don't want to reabsorb as much. We want to reabsorb less so we can pee out more of it, right? Because of our intake. Well, that decrease in reabsorption tends to increase the flow rate. So you have GFR increasing the flow rate, and you have reduced sodium reabsorption also increasing the flow rate. Remember, if you reduce reabsorption, you're going to end up with more fluid in the tubule, right? Because of osmosis. So if you're reabsorbing less salt, you're reabsorbing less water. So you have a bigger volume going through this system. All right, and then we get this sort of strange effect where the decrease in aldosterone and the increase in tubular flow rate have kind of an opposite effect, okay? This box is potassium secretion at the cortical collecting ducts. In other words, how effectively are we putting potassium in the urine to get rid of it? Decreasing aldosterone is going to tend to reduce our potassium secretion, right? That's the mechanism. But increasing tubular flow rate is going to end up increasing our potassium secretion because we have more fluid flowing through. More fluid is more exposure to potassium, so we get an increase. Now, what's weird is these two sort of partially cancel. So what that means, like, why am I going through this? Remember I said that aldosterone is this weird, sits in the middle of sodium and potassium. This is what allows us to regulate our sodium intake separate from our potassium intake, because these two factors cancel out. So it means that when we release or when we decrease aldosterone because of an increase in sodium, we don't get an increase in potassium because of this canceling out. So anything that increases flow rate will tend to increase potassium secretion. So this effect means that decreasing aldosterone to allow for sodium excretion, we can still have without causing a high potassium. So this is the mechanism by which we can separate the two effects of aldosterone, sodium retention and potassium excretion. This diagram, all this is proving to you is that as flow rate increases, potassium secretion also increases. It's proving this part right here. This plus is being proved by that graph. Okay, so regardless of what our potassium level in our diet is, the more flow rate you have, the greater the secretion rate is. And that offsets the reduction in aldosterone-driven potassium secretion.